Good morning. Christina Forbes here, wife of seriously injured worker Lauren Forbes. This video is in relation to Dr. Gershman. I know a few of you injured workers out there have had to deal with Dr. Gershman. There was actually a bit about him in one of the local papers here on the island a couple of years ago. I'll have to go back and find that piece for you. What I was able to find that I found very, very interesting was Dr. Gershman's actual report. Now, as you know from a previous video that I was showing you, that Lauren's Dr. Scruton, had faxed off this letter here stating that Mr. Forbes' diagnosis of reflex sympathetic dystrophy is conclusive. The orthopedic surgeon in the bone scan done in Comox seemed to suggest that this is the case. Apparently, Mr. Forbes was seen in Victoria by a Dr. Gershman, a specialist who rehabilitates people with this problem. This was a fairly brief visit and no medical information was given. Mr. Forbes was told he definitely did not have RSD, which I find to be a very presumptuous statement. So as you remember, just give me 1 second here. As you remember, that was June 23rd, 2006. As you remember this piece, I had pulled it out a little while ago. So there it is. Dr. Joan Scruton, Mr. Forbes, reflex sympathetic dystrophy. So you know how I had said there that Dr. Scruton had wrote that no medical information was given at the time Lauren had seen Dr. Gershman. So I found Dr. Gershman's report, Summit Medical, Victoria, Dr. Gershman. Right there. You see that? Fucking asshole. So anyways, right up on the top, the very, very, very first sentence. Oh, pardon me. He has been referred along with his medical information, and in brackets, look, in brackets, oh, pardon me, let me just try and correct that there. Oh, in brackets, what does it say? Which came after my visit with him. See that right there? Yeah, Dr. Gershman even admits that Lauren's medical information came sometime after. So, he's been referred along with his medical information, in brackets, which came after my visit with him, end brackets, and a consult note from a medical advisor for clarification of his diagnosis. It has been suggested that he has bilateral arm or upper extremity CRPS to account for his ongoing pain that is out of proportion to any obvious underlying pathology. Any obvious underlying pathology, wouldn't the K-wire and the fixation screw in his elbow be obvious pathology for ongoing pain? Considering that it's right at the medial and radial nerves, like that I'm not a doctor. He has not returned to this point. Apparently, he tried recently after attending an OR2 program at Summit Nanaimo facility, and he did not do much of anything when he did try to return to work. He's been off work since his bilateral arm fractures and does not feel that he should have been working anyways. He told me that he had 3 fractures thoracic vertebrae in April a year ago, which was mismanaged, in his opinion, by Workers' Compensation Board, and this has him quite angry. He said the reason why he fell off the scaffolding fracturing his arms was because of ongoing spine pain and the lack of mobility, because normally, apparently, in brackets, he would have been able to prevent the fall. He tells me that he has researched reflex sympathetic dystrophy and says that he has stage 3. He says that he wants to have some nerve blocks. He says it is his understanding that he will never get better and his situation will only get worse, despite requesting nerve blocks. He bases this on what he has been reading and what he says his family physician has told him. The fellow lives in Sayward and voices a lot of anger at his case manager, the Workers' Compensation Board, and he tells me that nobody has explained to him where his fractures were in his arms, and he voices a lot of frustration with his orthopedic surgeon. So, okay, he is under a lot of financial pressure at this point. history. He tells me that on September 19th he was on some scaffolding. He was up about 8 feet. 3 or 4 of the brakes were on, but that one was not. Slipped and he fell. He said normally he would have been able to throw himself back up on the scaffolding and skateboard it, but his back fractures and lack of mobility prevented this, and the scaffolding came down. He's not too sure how he landed. Presumably he landed on both of his hands. He sustained a right scaphoid fracture, displaced fracture of the right radial neck by the sounds of it, and a comminuted interarticular fracture of the left radius. The radial head fracture was treated with open reduction and internal fixation, and the left wrist fracture with K-wire fixation. His scaphoid fracture on the right has been treated with casting. He has had physiotherapy and gone through an OR2 program. Overall, he feels like his fracture recovery progress is not regressing, and he complains of global thoracic pain. He complains of global arm pain from his shoulder all the way down. He says that he's injured his right shoulder, but nobody is looking at it. He says that his right arm is in pain and worse than the left. The left hurts down from the shoulder as well, but does not seem to bother the left shoulder as much as the right. He says the pain goes all the way to his upper back and causes spasms. He says that he's in pain 24 hours, 7 days a week. He says the more he does, the more pain comes in. It doesn't sound like he's doing very much at home at all. He describes bilateral global arm pain. He says both arms are constantly burning. It feels like road rash. He said both palms are sweating all the time. He said both palms used to change color, but not as much anymore. He says his right forearm swells, but not his fingers. He's had some wrist stiffness and some right elbow stiffness accounted for by the surgery. But he says he has avoided more stiffness because he keeps working his fingers. He has not noticed any cold sensations in the upper extremities, and he says when the pain increases, his arms shake. He says his nails have changed in that they've become a bit grooved. There are no hair changes. He thinks his skin might be shiny over his hands. He says his sleep has been poor and he cannot sleep more than 4 hours in a row ever since he's fractured his thoracic spine. The psychological assessment was completed, and it was noted that he had a difficult time growing up, and his test interpretation was noted to be valid. So, diagnosis. Major depressive disorder, recurrent, moderate to rule out cannabis use disorder, diagnosis deferred, depressive traits and conflicted interpersonal relationships noted. As addressed by physicians, marijuana use and possible adiagenetic effects of Percocets. The psychologist noticed that he did not currently meet the diagnosis criteria for statiform disorder, but might be at risk of developing a pain disorder. He had a few sessions of counseling which were apparently helpful. This thing will probably run past the 10-minute mark, so please look for Dr. Gershman too. Full psychological assessment is on file. He did complete DRAM, a psychologically and injury relationship questionnaire here at the clinic today, and the score was 17, and the MZUNG, or depressive scale score, was 52, placing him on the distress somatic category, indicating that the injury has him quite distressed and that he may be prone to sodomizing, which is consistent with his clinical presentation, and this score is often indicative of a very prolonged and difficult recovery time. He was visited with Dr. Van Setter on May 17th of 2006. Dr. Van Setter queried a diagnosis of sympathetic reflex dystrophy and arranged a bone scan. This bone scan was completed on the 2nd of June 2006. It was a 2-phase scan. The views of the right elbow were suboptimal. The intake was increased throughout the right elbow, wrists, and hands bilaterally. The radiologist felt that this was consistent with disuse or RSD, but could not make a reliable distinction. Dr. Van Setter noted that his right elbow was functional, but potentially a diagnostic intra-articular cortisone injection could be done, and if he responded favorably, then possible, excuse me, I have to cough. Okay. Then possible arthroscopic exploration, removal of the radial head screw, plus release of adhesions would be practical if done orthoscopically. Just about at the 10-minute mark, so I'm going to stop here. Please look for Dr. Gershman too, as we're going to get into, oh, good Lord, is it good. Dr. Gershman, by the time I finish this report, you are going to look like the world's worst doctor. And you are. Thank you very much. Look for video 2 for Dr. Gershman, the Forbes family.